Utah is in the throes of an opioid epidemic. Addiction to prescription pills is affecting every level of society here in Utah. Overdose deaths are on the rise, and if you or a loved one is struggling with addiction, please pay close attention to tonight's discussion. We have a panel of experts here to discuss prevention and treatment of opioid addiction, and we'll also talk with some people out here who've struggled with dependence on prescription drugs. And this is a young man who passed away as a result of a prescription drug overdose, prescription drug dependence. Friend of a radio show that we do, Radio from Hell. His name was Dane Olson. His mother is here tonight, and we'll be talking with her about the problem as well. Tonight's program, Use Only as Directed, Utah's Opioid Epidemic, now on episode 14 of What Do You Think, Utah? I'd like to introduce our panel tonight. We have with us down here, this is a great new setup. I like this. We're usually sitting on couches that look very comfortable and are not. So I think this is a kind of a nicer setup. We can kind of rest our elbows. Down here at the end of the table is Jay Bischoff. He's the director of the Intermountain Urological Institute. He's a Johns Hopkins Fellowship trained surgeon who serves urology patients and their families using best practice guidelines. His measured experience and the least invasive means possible of treating illnesses. The training he received over the past 8 years at Intermountain Healthcare has ignited him with a passion for quality improvement and given him a skill set to develop programs that improve patient outcomes while significantly reducing the cost of healthcare. He became aware of the opioid death epidemic about 8 years ago and has become a vocal advocate for appropriate use and drastic restrictions on using opioids. And we'll get into that because, very specifically, because opioids are a valuable tool. And so we need to talk about how you restrict their use and what the protocol is for that. So remind me if we don't get to that. Let's go into that.
Thank you.
Susanna Burt has been working in substance abuse and mental illness prevention since 2001. She has managed several prevention grants for Utah totaling over $20 million. Ms. Burt has chaired the Utah State Epidemiological Outcomes Work Group, Utah's evidence-based work group, and participates on Prevention Dimension Steering Committee, Use Only as Directed, and Utah Protecting Children Project. Ms. Burt received her bachelor's degree from Weber State University, go Wildcats, and works for the state of Utah the Division of Substance Abuse and Mental Health. Thanks for being here. Dr. Ray Ward is a family physician and a member of the Utah House of Representatives. His medical focus is on evidence-based primary care. Okay, that's the second time we've said evidence-based and evidence-based outcomes. Talk about that. He enjoys working with all ages of patients, including older Medicare patients. An area of focus has been in medication-assisted treatment of narcotic addiction, in particular with Suboxone, which can be a very valuable tool as well. And we'll talk about Suboxone treatment tonight. He's worked with this patient population. Dr. Ward has a lot of firsthand experience with the devastating effects of narcotics, and Dr. Ward, in his role as a legislator, has also sponsored legislation having to do with opioid and prescription medicines. And then to my left here, Angela Stander with the Utah Department of Health. She works as a prescription drug overdose prevention coordinator. Angela's worked for the Utah Department of Health for a year and has spent over 5 years working in substance abuse treatment and prevention. She focuses on community level prevention. For the past 2 years, she received a Bachelor of Science degree in health promotion from Go Wildcats, Weber State University, and is a certified health education specialist. Angela believes that a comprehensive public health approach is necessary for combating prescription drug abuse. Anything that we talk about tonight, you can find further statistics and further help at a website useonlyasdirected.org. That's where you'll find some statistics like these. Every week in Utah, 9 people die as a result of a drug poisoning, 6 of which are a direct result of overdosing on prescription medication. Every month, 24 individuals die from prescription opioid overdoses in Utah. Now, if these deaths were caused by some mysterious virus or a poisoned food source of some kind, and 9 people were dying every week, the state would be in an absolute panic. Everybody would be talking about it. What do we do? What do we do? Why are we not in an absolute panic about these opioid prescription deaths? Let's talk to you first.
You're exactly right. Opioid deaths far exceed motor vehicle accidents, and it's hard to crash your car in the state of Utah and not be on the news, even if you don't die. But kids are dying, adults are dying every day, and we're not. And we want to thank you, Bill, and your team for putting this together to increase awareness and spending an hour on the topic. It is a very complex topic, and you'll see tonight that there is not one quick and easy solution. We're going to talk about a 360 approach, how we all have to participate in this. That means the physicians have to decrease the amount of narcotics they're prescribing. We have some data that shows that we should do that and can. Patients have to just demand less. We need some help with our legislators to help with this. We need help with addiction, recovery programs. There simply isn't enough money for that. I liken this to a toxic spill. So we have a toxic spill with narcotic overdose deaths. We need to stop the spill, and then we have to mop up this huge disaster that is out there. And that's where this is essentially a call to every single person in the state of Utah to help and say, what can I do? What is my role? What part can I play in stopping this problem?
Dr. Ward, so you're a physician. What sort of medicine do you practice?
Primary care.
Primary care. So you have occasion to prescribe opioids, I would imagine.
Sure.
Talk about that as a physician.
Well, I guess I have 3 ways that I think of opioids. As a primary care physician, a lot of times you will write a short-term prescription. Somebody had something that go wrong that's going to hurt them for a short term, and you have to decide how many opioids you're going to write for them. Then you have a lot of patients who have chronic pain that goes on a long, long time, and you've got to decide whether or not you're going to write opioids for them. And frankly, as people move around, you have primary care patients come into your practice who are already on opioids. And so then you got to decide if you're going to continue to write the opioids for them or go through the difficult process of trying to wean them off, which is always immensely difficult. And in my office, I also write Suboxone prescriptions. And so I see firsthand people whose lives have been ruined by a narcotic addiction, and hopefully the Suboxone can help them.
Well, so a couple of things come to mind there. First of all of those decisions that you talk about that you have to make, I don't know how anybody could. I mean, you have to have an awful lot of knowledge and intuition and skill to be able to guide your patients through this kind of thing. And is every doctor up to that challenge?
Well, doctors are individuals too, right? And they are going to get different life experiences, and they're going to read different articles and change their prescribing habits as time goes on. And the problem that we're talking about has not been around for centuries. It's been around about 20 years. And you can look back 20 years ago and you can see what happened. What happened was we had new pharmaceutical products, new pharmaceutical narcotics come on the market that were touted as being safer. And at the same time, it was touted in medical education that it was the doctor's moral responsibility to reduce the pain to zero, together with the idea that this was a safe, effective way to do it. And so all those things coming together, doctors changed their habits and they started writing a lot more narcotics, and it's just taken us a while to see how much damage we've done. It's not safe. It's not even effective, but turning the ship back around is going to require a lot of work.
Who wants to address this one? What does Big Pharma have to do with this? What do the big pharmaceutical companies have to do with this problem we find ourselves in today? Anything?
Well, we know that back in the year 2000, the Joint Commission that accredits hospitals created what they called the fifth vital sign, which was pain. And starting in 2000, we were all afraid of having a patient in pain when the inspectors were in the hospital. It was at that time that Big Pharma started to launch a large variety of narcotics in conjunction with that to try and help decrease the pain. And if you look, Bill, at the statistics of opioid deaths, it starts to accelerate from the year 2000. And that's where we are definitely behind the power curve of catching ourselves and again mopping up this huge toxic spill that we have, which is daily deaths of narcotic overdoses. And not just in Utah, but across the entire United States.
You mentioned Suboxone, and I was going to talk about that a little later, but you brought it up. I know an individual who I never would have suspected had ever had an addiction problem.
You can't tell by looking.
And he said to me one day, and he's a very healthy, fit person. I mean, and he said to me one day, you know, I used to be addicted to, and I forget what it was. And I said, what? He said, yeah, I almost died. I was addicted to OxyContin or I don't know what. And I said, what? He said, yeah, the only thing that keeps me alive now is Suboxone. And that's when the first time I'd ever heard of that. And he explained what that was to me. It seems kind of interesting or odd that we trade one sort of pill for another sort of pill, but talk about Suboxone treatment maybe, if you will.
Well, to be clear, Suboxone or buprenorphine is still a narcotic. Yeah. It still binds a narcotic receptor. A person on it is still dependent on it, and if they go off it suddenly, we'll have withdrawal that is just as difficult to get through as withdrawal from any other narcotic. But it is safer. It's able to be put in a steady level into the person so that they're not high and then in withdrawal and high and in withdrawal. And you have a lot of patients whose lives were in shambles before, who now that they're on this other medication are able to function quite well. You know, that still doesn't count as putting the patient back completely whole, as they would be if they hadn't got put on narcotics in the first place, because they're still dependent on this substance. But there's a lot of people that it does help.
Do you stay on it forever, or is the idea to gradually wean yourself off of Suboxone?
So I can tell you my own personal experience as a physician with the patients that I've worked with. In my experience, for most patients, it's pretty easy. If you go slow, changing the dose every month to get down to a medium low dose, which to me is 4 milligrams a day, and then to get off of that is very, very difficult. So you can get down to a low dose, and you try with every patient, and a few of them make it through and get off, but there's a fair amount that you try and it doesn't work, and you
It's like I was addicted to nicotine for years and years and years. I smoked cigarettes and just, it was awful. And I finally managed to quit with nicotine gum, to which I was then addicted to for a long time. I couldn't give up the gum. I think I chewed the gum for 3 or 4 years, and then finally I said, well, I could, and I did. I was able to wean myself off the gum, but similar situation.
Yeah, and some people, once you get them on a low dose of the Suboxone, and their life is stable for a couple years, and so the person they were buying pills from illegally, they're not around that person, or they're not in a bad situation, then maybe they have enough life fortitude to get off. But it's not easy to get off it.
Let's talk about addiction. You see people with addictions all the time.
Well, I actually work in prevention, so I work with the Division of Substance Abuse and Mental Health.
Do you deal with?
She used to, but.
Angela, do you deal with people with addictions mostly?
Yeah, I'm more on the prevention end right now, but I have spent plenty of years dealing with addicts.
I think people who are not addicted to substances don't understand the nature of addiction and are not very tolerant of it.
There's definitely a big problem with stigma right now, and they're thinking that, this is something people are doing, just to party and have a good time. We've heard recently, but when it gets deep, really bad, people are doing this just to function, to stay alive, to not go into these terrible withdrawals, and to function on the day-to-day. So we really got to work on changing the stigma. And also there's this idea that addiction is kind of something that other people or, the people on the street corner are dealing with, but everyone's really susceptible, and that's why when we talk about prevention, you don't know the susceptibility to addiction is just there for everyone. So that's why we got to be careful with how we, not starting people on this route, because you might think that, that'll never be me, but most of these people who are in the depths of this started out thinking that'll never be me.
Well, I'll
never get down that way.
That's one of the problems I think with dealing with it, is that people who don't understand the nature of addiction are not tolerant of it and not understanding of it, and they say things like, well, why don't you just stop?
It's not that easy.
Yeah. What do we do, Ms. Burt, for prevention?
Well, again, reducing the stigma does help, but as far as families or communities goes, really raising the awareness of what the pills or drugs or other substances can do to our bodies, to our brains. And as parents, talking, bonding, spending time doing positive activities. There's lots of things we can do and get out in the world without having to take medications or other stimulants to make us feel better.
Mm-hmm.
So.
Where do we need to start with prevention?
Lots of ways. Ray wants to tackle this one.
So
Go
there's
ahead.
so many places, but I think one really key thing is simply to have a broader public awareness, meaning just the average person as well as the average physician, of how addicting these medicines are. Opiates are the most addicting substance ever identified of any kind.
Worse than nicotine?
Yes, so nicotine is in second place, actually.
Is it
So,
really?
Yes, it is.
Oh.
So I don't mean to say, there's other things that might kill you more often if you took them, but just by addicting, you say if you put this number of patients on it, how many become completely dependent on it? And you can measure that for all the different substances that we have out there. And this is first place, nicotine is second place, but nicotine, although it may well kill you in 30 years, won't kill you today and won't cause you to lose your job and custody of your kids and get thrown in jail.
Get in car wrecks.
Right.
Yeah.
So, Bill, you talked on something that's really important, and that is prevention. And we absolutely need to increase awareness in a couple of areas. Number one, you can become dependent in as few as 7 days of taking narcotics. In as few as 7 days. That's the first statistic everybody needs to be aware of. The next is, I'd like to draw our attention to a very important study that came out in the journal Pediatrics last year. This was a beautiful study. They took 6,600 18-year-olds from different high schools in 3 different school districts. And they screened them for not being at risk for an addiction. So these were kids who were not drinking alcohol. These are kids who are not smoking marijuana, were not using cigarettes, were not using prescription pain medication. So they probably had to go to a lot of school districts, but in the end, they got 6,600 of these kids. They followed these kids to the age of 23. And if those, in that group of 6,600 kids not at risk for addiction, if they were prescribed opioids one time during that 18 to 23-year age group, 30% of those kids went on to have an addiction, difficulty, or problem struggling with opioids being exposed one time. We have to increase awareness as to how powerfully addictive these medications are. So one of your questions was, what do we do about prevention? Patients need to know that these are not safe. And it's okay to say to your doctor, I think I'm going to try Tylenol and ibuprofen, and if I need these narcotics, I'll get them filled. And what you'll find is you may not actually need those narcotics. Let me give you one more example. 2 examples. I have 2 urology partners. I'm a urologic oncologist. I have 2 partners who practice essentially the same practice that I have. A lot of prostate cancer, kidney stones. One of them moved to Switzerland to practice. So we're all jealous of him, of course. The other one moved to New Zealand to practice 6 years ago. He has not written one narcotic prescription in 6 years. Not one. And so what do they use? That's what you're asking.
Yeah, is there some legal restriction that he can't do it?
It's interesting, in those countries, New Zealand and Switzerland, the only person in your life who can write narcotics for you is your primary care doctor. No one else can, so they keep tight control of that. They use all of the non-narcotic medicines to help treat your pain so that you don't need narcotics. The US population is 5% of the world's population. For some Americans, that's a surprise.
Yeah.
We consume 98% of the world's supply of oxycodone.
We're number one.
We're number one. Bill, we are so special in America that we have special pain, we have special needs. So the Swiss don't need narcotics, New Zealand doesn't need narcotics, but in America we consume 98%. And one of us in Utah dies every day, and the statistics continue to grow completely out of control. Where's prevention? Doctors need to prescribe less. Let's use the non-narcotics. Patients need to say, I'm going to take the narcotic prescription, I'm not going to fill it unless I really need it, and if I do, I'm going to take it for a couple days, I'm going to destroy the rest.
Hang on one second, we'll get to your question. Don't be you're fine, you're great. You will be great, just don't worry, okay? Let me just ask one other question about that. And this is from personal experience. I've had, unfortunately, several different surgeries in the last. I had a knee surgery. I had, and every time I was given prescription narcotics. Now I always tell the doctor that I'm allergic to them and they make me itch, and they say, well, let's see if we can find one that'll. Because there's a wide variety of them too that I wasn't aware of. There are just so many different varieties of these narcotics.
A full menu.
Yeah, and they all, because I guess it's opioids, they all make me itchy and stuff. So, but nobody ever hesitated to prescribe them. And I mean, these are respected, good physicians and surgeons, but they never said try something else before you try these. Now, it's easy for me to get myself off of them as quick as I can because I can't stand them. But
so you touched on, Bill, a big problem. It's a complex problem, like I said at the beginning. There isn't one answer. Your physician is going to be graded on how happy you are. And somebody, your insurance company, the hospital is going to call you. They're going to say, Bill, you had surgery. Tell me about your doctor. Yeah. Did you like him? No, I hated him. Why do you hate him? He didn't give me narcotics. So, and then we're going to have a score. We're going to have an online score, just like your radio show. Yeah. Your score on your radio show is pretty high. Yeah, it's lasted a long time. Well, it's pretty impressive. So all the doctors, we're all out there competing with the patients. You have to spend a lot of time. And I tell my patients, I'm very concerned about your pain. It's really important to me. So I'm going to put you on extra strength Tylenol around the clock. We actually give Tylenol when you fall asleep in the operating room because it's so powerful. I'm going to give you ibuprofen. I need you to take it around the clock. And I'm going to give you 6 very powerful narcotic tablets, not 60, not 30, 6. And if you have need for them, they are there. And take a half. And patients come back and they say, I didn't think, Bischoff, that you were going to actually be right on that. And you were right. I didn't even take these. I took 1, I took 2. The problem is we give you 30, we give you 60, or some football score. I don't know how we got stuck with that, 21, 28. And then you don't use them, and somebody else comes by your house and steals them from you, uses them, or you do overuse them. Like we said, you can become addicted in just 7 days.
Remind me, I want to talk about, and maybe with Representative Ward, about if there is some database where we can track all of this stuff and physicians can tap into it and that sort of thing. But let's get to this young woman who is. You're cringing? Are you nervous?
I'm a little nervous.
What's your name?
Well, I ask a question every time I come, so that's why I'm in phone. But I'm Janie.
Hi.
And okay, so I have a question. I actually have 2 questions. Actually, I have a million, but I'm going to put it down to 2. So my first question is, what's the difference between so you say that these people need these medications to have a fulfilling life in what they think, and they need them every day or else they'll die because of the withdrawals. So I'm lucky to not be addicted to any opiate or anything. I feel lucky. I have loved ones who are, but I do know, what's the difference between, I don't know, gabapentin or an antidepressant or something that I know, I need every day, and if I don't take it, then I feel like I don't have a good quality of life, even though it's not a controlled substance.
So we're talking about 2 different things here, right?
Yeah.
We're talking about opioids, and then you're saying that you need to take
like an antidepressant
mood altering drugs every day. They're different drugs, are they not?
Yeah, so if a medicine is a controlled substance, if it's addicting, then, I mean, any medicine, if you stop taking it, might quit working, right? Of course, it would quit working, and then whatever you had before might still be there. But if something's addicting, it actually makes physical changes in your brain, in your body, that causes very, very unpleasant symptoms because you used to have it and now you don't. And that is so. Another thing that's important to say is no one ever died from narcotic withdrawal. It doesn't kill you, it doesn't hurt you, but it makes you feel like you're gonna die, and it makes you feel like you wanna die. It feels awful, and it goes on, and you know, and you're correct, that if you take that narcotic again, all of that will go away as soon as you take the narcotic again. It's just a powerful force that drives people back to still be on it.
But these drugs that you're talking about, I don't know.
So gabapentin will quit.
Zoloft, and I don't know if that's the one that's still used, but
Yes.
those are not addictive.
Correct.
Okay. So is that what you wanted to know?
Yeah, just, I mean, if you need it every day, isn't it like the same problem?
Well, you need food every day too. You know, it's not just because you need something every day doesn't mean you're addicted to it.
Correct. And so you're talking about an antidepressant, and you take it every day so that it helps stabilize your mood. Gabapentin, a wonderful drug, not addictive, which is very helpful for neurologic disorders, and it's also extremely helpful for pain. And we're using that now. When you come to see us for surgery, we give you gabapentin in the waiting room and Tylenol in the waiting room because it drops the amount of medication we have to give you to control your pain postoperatively. But those are medications, if you stop taking them, then maybe your mood starts to swing back the other way. With the narcotics, when you stop them, you start to get anxious, very fidgety, nausea, vomiting, diarrhea, and impressive diarrhea, and profuse sweating, crampy abdominal pain, to the point where you'll lay down in your room and just curl up in a ball and wait.
We have in the audience, I know, Doug, would you mind coming up and to the microphone and telling your story? Doug is an employee of ours, Broadway Media, and when he heard we were doing this show, he said, oh, I'd love to come and tell my story about being addicted to opioids. Doug, when we first met him some years ago, he was a budding radio person and was really talented. And then we fired his ass because he was unstable. And as it turned out, he was unstable because of pill addiction.
Oxycontins.
Yeah. And then Doug was rehired. How long have you been working for us now?
Year and a half.
Year and a half after being gone from our
10
company
years.
for how long?
10 years.
10 years.
Yep.
And they hired Doug, and I said, "What? You hired Doug Wild? Don't you know?" And they said, "Well, he's turned his life around, and he's become he's an incredible asset to radio. He's a very talented production guy, and does a great job and works hard. But tell your story if you would, Doug."
Well, it started in high school. I got my wisdom teeth out, and of course, here you go. Here's the bottle. And then after high school, got into a motorcycle accident. Here you go. Here's the bottle. And that kind of really started it. The back pain is really what has kept everything at bay. But after that, out of the house, doing my own thing, and early 2000s, when Oxycontins were the big thing, that was the thing to do. And this is right around the time when I was working with Bill, and it got pretty bad. We were taking 4, 5, 80 milligram Oxycontins a day. I can't, and I did that for 2 or 3 years.
And what did that do, Doug, to your life? I mean, your behavior?
What ruined it?
I mean, what did you? I don't remember the circumstances of why you were.
I stole.
That's what
Yeah,
you stole stuff.
I was stealing to get money to get the drugs, so I could feel normal.
So you didn't feel it didn't make you feel on top of the world. It just made you feel normal.
At the point I was at, no.
Yeah.
It was making me feel normal. Shortly after that, I believe, before that, I went to rehab. And they taught me the necessary tools, but I still relapsed. And I remember one thing that really stuck out to me. They told me in rehab was, 8 out of 10 of you here will relapse. And I just got so mad. No, that's not me. That's not going to be me. And sure enough, shortly after I relapsed, and I went full bore, and then I figured out Oxycontins are too expensive, so I went on to the next dirtiest thing, which was heroin. I was shooting up. It was my life really. It took a turn for the worse. I was homeless. It was pretty bad.
What turned it around for you?
Suboxone. Yep. I had taken it before, and I knew what the effects were if I tried to abuse any form of opioid. And I'm 12 years taking Suboxone. And here's my problem, is I'm deathly afraid of getting off of it. I'm ready to get off of it. I feel like my life is complete. I have a family, 2 kids, I'm married.
You're a valued employee.
And I'm scared to get off of it. You know, I get one thing to get off of this thing, and just like what Bill said before, I'm trading one thing for another. Now I'm at the point in my life where I don't want to trade something for another. So how do I get off of the Suboxone is my question.
Yeah.
And I've done it before, and it was miserable. It was worse than getting off of Oxycontin. It was worse than heroin withdrawals.
Right.
So why would you give somebody something worse? And I understand the naloxone's in there, and it's blocking everything else.
Well,
So
let's address it.
Yeah.
How could Doug get himself off of Suboxone?
So Doug, the reason you use Suboxone is, first of all, what an amazing story.
Congratulations.
And yeah, what an amazing story. And the fact that you're still alive, I think you would say, yeah, that is pretty remarkable. People die from this addiction. They don't wake up one day and say, I want to become a narcotic addict. It seems like that would be a lot of fun. They start with prescription pain medications. 80% of current heroin users started with prescription pain medication they got for a legitimate reason. 80%, just like your story, Doug. And then, if 6 tablets makes you feel normal this week, then how many are you going to need in a month? More. And the window between feeling normal and stopping breathing gets shorter every month, and that's how you die. You don't die because you willingly overdose. You die because you just need to feel normal, and in order to feel normal, you have to escalate, and you hit the point where it stops breathing. That's the first thing. Rehab, you touched on a really important point, is rehab. With some work that we've done with the University of Utah and some of their research, it shows that the average narcotic addict has to go through rehab 7 times. Angela, is that your 7 times?
Try not to use that stat too much anymore.
What would you say it is?
There used to be the kind of the 3/4 rule or something, but
Yeah.
it's common, yeah. Or more, a lot of them are going to take more than one rehab trip.
So the reason I mention that is because when you go through one rehab and you relapse, you can get discouraged and just throw in the towel. And the statistics show that to help rewire that brain that's become dependent on it, it takes multiple passes through this.
It was about 7 times. It was around there. I tried, and then finally I committed to the Suboxone program. And
So the Suboxone helps get you to where you are right now. And Dr. Ward can probably address a little bit weaning off Suboxone. It's a gradual, long process.
You mentioned before that you can get down to 4 milligrams, but then it's really hard. Where are you at?
I was 2.5, but the last time I did it,
Films or milligrams?
milligrams. Yep, just a half of a tab. The last time I tapered down, I was down to crumbs, and it was horrendous for almost a month. So I decided to go right back on.
So that matches my experience, right? So we start out by telling ourselves, oh, if only I taper it a little slower, then I can taper off without going through the withdrawal. And my experience is that you find some low dose that's not a happy medium, it's an unhappy medium where the person kind of permanently is in some degree of withdrawal. And at a certain point, that's no longer helpful. At a certain point, then you got to jump off, and you can use other medicines to try and help and get through that. And because it's so difficult, I mean, some people do make it through that, and then they're so happy out the other side, and others make it part of the way through, and they say, I can't, and then you're back on some low dose again.
Is there, Doug, and you don't like the dependence on it, but is there at some point where maybe you just have to say, I've damaged myself to a certain point?
I know I have.
And that's this is what I need to do to live? This is where I need to stay, to live and not be, an addict anymore?
That's what I told myself in 2009, the first time that I tried to get off of Suboxone. And I took the slow and steady approach. Again, I was down to crumbs. And again, horrendous withdrawals, and it was affecting my job, my life, everything. So I said, you know what? It's okay. If I need to get back on it, then I'll get back on it, stay at a low dose, and see what happens. So here we are, 2016, still at that same low dose, but I am even more motivated to get off of it because it affects me. When I was in rehab and I was completely sober, I know what sobriety feels like, and I still don't. I know I'm sober, but I'm not. It's you know what I'm saying. I'm free from Oxycontins and everything else, but I'm not. I'm still on Suboxone. So I can't technically say that I'm sober, and that's what I'm striving for.
Is there any program that you can recommend for somebody like Doug or anybody else listening to this to get him past that point? Is there anything?
Angela, do you want to talk about that?
I don't have a specific program with substance abuse and mental health. I don't know with your guys' programs, but
Well, I think that it's because of your experience in the previous.
yeah, it's a challenge right now, and I still at the Department of Health get a lot of phone calls from families, a lot of wives saying, my husband, things are a lot better than when he was using illicit drugs and abusing these, but we didn't think this would be a lifelong journey of Suboxone, and I don't have the answers right now, and it sounds like Dr. Ward doesn't either, but this is where we've arrived to, and like we said, it's 20 years in the making. It's still pretty fresh of a terrible nightmare that we've created here, and I think Suboxone's kind of one way we're headed out of it, but we're not completely there yet, I would say.
I think 3 important things come from that. There are a lot of people just like Doug, but they don't succeed. Actually, there aren't as many people like you, Doug, as you think there are, because they just don't get things back together like you have. You're working again, you're married, you're raising children. It's just really super impressive.
Doug, you should be proud of where you are and not beat yourself up about it. This guy I talked about that I know earlier too. Man, he's just a stellar human being, as I think you are, and just a bright, smart guy who works hard every day, and he's amazing, and nobody would know if you didn't tell us. Nobody would know.
See, there are a lot
and that's great.
So are you doing anything other than Suboxone, like any therapy or any NA groups?
This is weird for me to say that, but I don't believe in those groups.
Okay.
I found them to be toxic.
Okay.
I still pull out my tools that I learned in rehab, and I go through some of those every now and then. I just think for me, and everybody's different, but again, it was a toxic environment. I would go to these classes, and it was people it was a big brag. People are telling their stories, and for me as a drug addict, I didn't want to hear those. I wanted to forget about that stuff. I wanted to be around a whole different crowd of people. And that's what helped me. And I know everybody's situation is different, but I decided to surround myself with different people. And that's what helped.
Yeah, we call that relocation. But
yes.
But remember this: you're going to be recovery even with Suboxone. You'll be in recovery
Yeah.
even without Suboxone. You'll be in recovery, and it will be
Agree.
a struggle every single day.
Agree.
And again, I would applaud you for all the strides you've made. That's amazing. So
Yeah.
don't be so hard on yourself for having that something to help you get through the day on that.
So, do I stay on it?
Yes.
Well, Doug, let me just say it from a practical standpoint. What's the alternative? Not good, right?
So many patients, just like you, need to stay on that.
Okay.
And it illustrates that point. It illustrates the point that we need better rehab centers. And that's a huge deficit. We have so many people who are addicted from prescription pain medication who are now addicted to heroin, and they just can't get into rehab. And it takes more than 1 or 2 passes to get through rehab, and there just isn't the access for that. We need that. That's part of cleaning up the toxic spill is rehab. And then we have to continue to go back to prevention. I'll bet, Doug, there's so many times in your life when you said, oh, I just wish.
Yeah. Yep.
And that's where it
Yep.
comes to us. Parents need to be vigilant about the prescriptions. Husbands and wives, partners. When your partner has an operation, you be the steward over those narcotics, and you just get them out of there as soon as you can.
What do we? Yeah, Dr. Ward.
And somewhere out there is the doctor that wrote you that narcotic after your motorcycle wreck who has no idea
Yeah.
that they damaged
Right.
you.
Right.
Right?
Yep.
And so that's why it's so important to get the stories out there. I mean, everybody needs feedback about their performance to be able to improve it. And right
That
now, it just doesn't come back to the doctor to realize, oh, I just permanently damaged that person. And that feedback needs to be there.
I want to get to another story in a second, Doug. Thanks for
Absolutely.
doing that.
Thank you.
Let's talk just quickly the state of Utah, prevention. Keeping this from happening. What is the state of Utah doing to this? A lot
Where
of
do we
stuff.
start? Yeah, we have a lot going on. We actually have in case you hadn't heard, we just received a new grant that would help with more prevention in the statewide. And our emphasis is going to be on working with coalitions to help that community norm where you have the discussion, setting the norms from the community of this is okay or this is not okay, teaching them how to say, having the discussion, just like Dr. Bischoff said, with their doctors, with their family members. And the other things to keep in mind is that we want not just communities, but families. You have parents, you have aunts and uncles, everyone can have those conversations. You want to make sure that they're spending the time, setting the boundaries, saying this is okay, and this is what, as you go into the doctor's office, this is what we want to ask. And it's okay to ask those questions. Usually they're 15-minute sessions, not sessions, but visits. But you can get a lot from your doctor in that time period and to be advocates for yourself. But as far as programming, we've got the Use Only as Directed program going on, the campaign that shares safe use, safe storage, safe disposal, and the new one, which is Speak Out. I don't know.
Speak out, opt out, throw out.
Yeah.
So, just feel empowered to have that conversation with your doctor and come up with another option, opt out of that, and then get rid of them if that ends up being the case that you end up with them.
useonlyasdirected.org
Correct.
has a tremendous amount of preventative material as well.
Great
Yeah.
for questions and answers.
Yeah.
And Bill, I also want to mention, you told us to remind you about something called the Controlled Substance Database. That's a big thing that we're doing
Yes.
for prevention. So a big thing that we're doing, focusing on the state is provider education. We have awesome doctor advocates here that are out there saying that it's okay to change your behavior.
So
Go
the
ahead.
controlled substance database, again, though, let's emphasize what that is because there's has not been any mechanism for a doctor to go check and see if his patient has been to other doctors and has been
Yeah.
prescribed. Because people will lie, they'll say, "Oh no,
Yeah, there's something we used to call doctor shopping that got really easy to do back when this started getting big, and that's getting harder to do, and that's been a huge beneficial prevention tool, is this controlled substance database that every time a prescriber, and the doctors can talk more about it, they work with it more, but every time that one of these dangerous narcotics, opioids, is prescribed, it's put into that record. So if they do go to another doctor down the street the next day or another pharmacy, there is a track record of where that person's been and what they've been given.
like the surgeries I've had, I've always have to show my ID to get that
Right.
Yeah,
medication.
within just a couple of, literally just less than 60 seconds, we can pull up that state database. We can also search other states now. And when patients come in and their story's just a little bit off, just doesn't quite add up, we just run back and check that. And you can just print it off and walk into the room and say, it's interesting, you're having this pain, but you saw Dr. Ward yesterday, and you were at Intermountain Medical Center the day before, and I'm adding up 300, this is an actual case, 300 narcotic tablets that you've been prescribed in the last 2 weeks.
Does it red flag at the pharmacy as well?
A pharmacist is able to look at it also.
But it doesn't,
No.
there should be a mechanism
There
that
should
it
be.
just,
Working on it.
as you go, is
That
there-
would be ideal, yes.
that as you go to
Yes.
the pharmacy and they say your ID, and they run your ID and they go,
Absolutely right.
Can't
And
do it.
We're asking people like Dr. Representative Ward to think about that. Also, Utah's one of the states in the union where if a pharmacist sees a prescription that they really think is fraudulent, they're not required to report that to law enforcement. But in other states, it is required for them to report that.
yes, sir.
Wow. Well, I have a very along the exact same lines that you were talking about, but a little bit askew from a different perspective. About 21 years ago, I had a very, very terrible life-threatening accident. I was a quadriplegic, broke my neck, shattered 4 vertebrae. They are now fused together with almost 1.5 pounds of titanium holding my neck together. 4 years after that, I broke my back. Also a very, very traumatic situation, scalped my head at the same time. At that point, when I was a quadriplegic, I was quadriplegic for quite some time, and then had a miraculous surgery that changed everything. This is the exact same break that Christopher Reeves suffered from and eventually died from, and I had a wonderful doctor. However, I was to get to the point, I was in, I had chronic pain, very, very severe pain after I had gained my mobility back for years and years and years. I would say 15 years, and I was on very, very heavy opioids. Well, I wouldn't say that. I actually never did Oxycontin. It was never that far. I just needed to actually live my life for an extended amount of time while I was actually getting to the point where I could get the pain to go away. I actually found a different way to get the pain to go away, and that was all within my mind. But I was on opioids for about 15 years to live my life. And I was tempted to actually abuse them, I guess you could say, but I did not like them because I actually had to use them every day in order to live my life, in order to have a job, in order to have my family.
So is what you're leading to here, and we're kind of going to run out of time here, but that is it possible then that someone can use these drugs and effectively for a long period of time and not be addicted? Did you not become?
I hated it. I hated it. I wanted to be.
You didn't become addicted to the medication?
No, I never did. It was actually, and no, don't get me wrong. I know many people that had been, and this is very much an epidemic. Absolutely.
I mean that we do run up against this problem that these medications in some ways are miraculous and are a tool that can be used effectively in some cases. Would we say that, Dr. Ward, Dr. Burke?
Well,
It's interesting, the literature is actually pretty weak that narcotics help get you through chronic pain situation. So a couple of questions there, Bill. Number one, most people who take narcotics that long become dependent on them. They become dependent on them for normal function.
and
Not
yes, I
everybody
was.
does,
That
but-
is
You
absolutely
were
many,
dependent
but
on
many do.
That is absolutely correct. So the dependency, yes, was there until I actually found a shift of mind to understand
Yes.
the pain better.
Right.
And so then I haven't actually touched a narcotic. Well, maybe off and on from my neck throws out every once in a while, and I actually do have to for maybe a week or so.
All right.
But my question is this: so I've had other breaks and other things, and I've realized that narcotics they work well for arm breaks or for other ailments or for surgeries.
Question.
But
What's your question?
I've noticed that nothing else, Tylenol or ibuprofen or nothing else actually touches on your nervous system, your spinal cord.
Right.
Ibuprofen doesn't.
And what's your
aspirin does
question?
not.
We need your question. I'm sorry.
Is there an alternative
Yes.
other than narcotics?
Yes. So a couple things very quickly. Gabapentin, Neurontin, great for neurologic pain. So can acupuncture, massage, hypnosis, so many other things that we don't touch on in America. Because we're Americans, so we can't be in pain, we can't be hungry, we can't be too warm or too cold. It's got to be fixed immediately. So we rush right to those instead of looking at some of these other alternatives. So yes, there are. In terms of Tylenol is so powerful that that's what mainly is in Vicodin and Percocet. It's mainly Tylenol with a little bit of narcotic. We give you Tylenol in the hospital IV when you go to sleep because it's so powerful. Tylenol, unfortunately, you have to take regularly. Ibuprofen and those sorts of things, they do work, but they don't work to chase pain. It works to help suppress pain. So yes, the quick answer to your question is there are a lot of alternatives, and you found one. You
Yes.
alluded to some sort of mindfulness or hypnosis or something that helped completely change your life. And we would say we kind of jump from acute pain and addiction to chronic pain, which is that's a 2-hour program, Bill.
We got another question back here. Can we get to that question or comment? Yes. What's your name?
My name's Hillary. I am a community pharmacist, and I'm glad that there's so much prevention out there, but until we get the word out there, people are still dying. That's why I'm a big advocate for naloxone, or brand name Narcan. And I have a hard time selling the idea to other pharmacists and other prescribers because they feel like they're condoning bad behavior or they're just using it as a tool to continue addiction. So I was wondering if you have experience with naloxone, if people use naloxone, that they actually use it to get help.
I think I know what that is, and there had been recent legislation in Utah about naloxone, hasn't there?
We've made some good steps in the legislature last year, but really there still is a broad community push of awareness so that people know about it in the community and so that pharmacists carry it and people can get to it easier. And I hope the next year or two gets us a lot.
So somebody needs to explain what it is exactly.
I can take that. I'm glad that you brought that up. I wish we had more time. It's definitely not something to be saved till the end, but we've wanted to talk about prevention. But I mean, this is prevention of death. And it's been said a lot. I won't steal it from the plums over at Utah Naloxone that have really pioneered this in Utah here. But Sam has always said that if you're dead, you can't recover. So when it comes to, are we enabling these people? Are we giving them a route to use and we'll save their life? No. There's nowhere we can begin
But what does naloxone
to recover.
do?
So naloxone is an antidote. Do you want to do it? You're the pharmacist.
It is
Let's hear
the
it.
opioid antagonist. It goes into those opioid receptors and it takes out the opioid, replaces it with
so
naloxone.
if someone has overdose,
Correct.
It returns breathing.
It
Yes.
knocks the
Within
narcotic off the
minutes.
receptor that's causing you not to breathe. And it's within seconds, these patients will wake up.
But you have a very small window, so that's why awareness is hugely important. And most of the legislation has been to get that in the hands of a close bystander, whether that's a friend or a family member, because there's a very small window to be able to reverse that overdose. Once that person is unconscious, once that's like Dr. Bischoff talked about, once a person has taken that much and their body is now shut down.
And I love the idea of naloxone as long as it is not separated from the idea of not using narcotics. So we're giving naloxone where I'm saying, I'm going to give you a prescription for narcotics, and this may kill you because you take too many, and so in case it does, I'm going to give you naloxone to reverse it. What I am saying is, let's not get to the point where you need naloxone. So let's not give you so many narcotics that you stop breathing. Let's give you all the alternatives, Tylenol, ibuprofen, all the nonsteroidals, gabapentin, Neurontin. Let's give you all of that. And let's
Stop
avoid
co-prescribing with benzos.
that. Yeah, that's a separate.
So can people go who have
Yeah.
family members who
So-
are addicted?
Yes, so you can get that. It used to be that you could only get it with a prescription from your doctor, but a lot of pharmacies, not all of them, all of Intermountain pharmacies have a collaborative practice where you can walk in and you can get it without a prescription.
Intermountain Healthcare?
Intermountain Healthcare, yeah. Or ask your doctor about it. And it doesn't have to, when we say third party, it doesn't have to be for you. If you have a struggling, I mean, to advocate for the families that are dealing with addicts, realizing that they could lose a loved one, you know, that's a very real reality. They can have that. So
You
there's
still have
tons
to
of ways
buy
to get
it,
it. You still have to buy it,
but
yes.
you don't have to have a
You don't have
prescription
to
to get it.
prescription. So
If
a
you
lot
do
of
have a
insurances will
prescription
cover
for it, insurance often covers it. And some prescription plans, no copay.
There you
So
go.
it's accessible. Just know that it's accessible and you can learn more about it.
Terry, you don't want to say anything? Yes, I do. Okay, quickly, come to the fore. This is the mother of this young man, Dane Olson. This is Terry Olson.
So just from a mother's perspective, I just want to share a couple things. The first one is to underscore the depth of the problem. I had 5 people I'd invited to come with me tonight, and each of them had an issue with a drug or overdose incident that has kept them from being here, which is one of my son's friends relapsed yesterday. His mother is now trying to get him back into another detox. Another healthcare professional who is also trying to get someone into detox. So the problem, whether we are aware of it or not, it's going on constantly, 24/7. I took a few notes while people were talking, and I just want to cover a couple things, and many of the points that I would bring up have been covered. But my son was 17 years old when he went out on an ATV with some friends. It tipped over on him, drug him for 30 feet, and he was delivered to the hospital with his right leg dangling, bones hanging out, serious risk for infection because it was full of gravel. Amazing doctors saved his life that night, and over the course of 10 days were able to put his leg back together, which initially told us was not going to be possible. He was obviously in a lot of pain. He was in the hospital for 10 days. He had a series of surgeries. He had a fasciotomy, if any of you know what that is. They had to open his leg up and leave it open because of the swelling to his muscle. That went on for almost 2 months with a wound vac. So he was on intense pain meds. At one of our follow-up appointments, our orthopedic surgeon kind of just in passing said, you know, we're probably going to have to taper him off of these drugs at some point. And my husband and I, being completely naive about this whole process, we're like, oh, okay. So after the fasciotomy had been completely closed, this is almost 2 years down the road, they took the titanium rod that was holding all the little bones together, and his last prescription was, we were almost out of it, and when he finished taking that, my husband handed him a bottle of extra strength Tylenol and said, okay, and we thought that was the end of it. Dane didn't want us to know that he was still struggling, so he started hitting up friends, and many of whom had had wisdom teeth removed and had an extra supply that they were happy to share with him for a nominal fee. This went on for a period of time until one of his friends overdosed on heroin and passed away, and he came to us and confessed and told us what a mess his life was. And we started again naively, because when he was hurt, there was a course of action. We knew exactly what to do. You called 911, the paramedics came, they took him to the hospital, everybody knew what to do. When we faced the addiction, we didn't know where to turn or what to do. So we were sent to a methadone clinic. And I'm thinking that this is going to be a couple-week thing, and then, we start talking to the counselors and stuff. 5 years later, after I had driven him to a methadone clinic every single day, and that was part of the time when he was a friend of the program, and methadone made Dane really groggy. So that's how he became sleepy kid around the station. So he could function because he wasn't worried about withdrawals and stuff, but he couldn't drive. He really couldn't hold down a job during all that period of time. And then we were introduced to Suboxone, which was a lot more expensive. And then we did that for a period of time, and then finally Dane reached a point he just wanted to be done. He says his father, again, the family and different people who have not had experience with addiction, in their mind he was still an addict, he was still taking drugs every day, and until he wasn't doing that, he wasn't clean. So under that kind of pressure and him wanting to please the people around him, he tapered off of it, and we had a big celebration that he was drug-free. 6 weeks later, that's the other problem with OxyContin is it is expensive and it's harder to get, so always along the line a friend will introduce him to heroin, which is much easier and cheaper and all that stuff. He got heroin. We ended him up in detox. He went to rehab. We thought we had him back. 6 weeks out of rehab, he relapsed again. He overdosed once and was revived with Narcan, and 2 weeks later, he was dead. So when you ask about getting off Suboxone, in my brain, I'm going, if I had not been so focused on my son being off drugs or being clean, that maybe I'd still have a son who had a chance at life. I can also tell you that addiction is not something anyone chooses, and it's not something they have control over. I watched my son beg, plead, bawl, because he hated his life so badly and the things that he had done. And every addict eventually will steal from their family, their friends, and if it doesn't get them what they need, they'll start shoplifting, and they often end up in jail. And the cycle, there is just not a great future for someone in that cycle. So the problem that I run into when we put our son's obituary in the newspaper and we talked about his struggle and that he passed away from a heroin overdose, I was inundated by people across the country and even out of the country who wanted me to give them some kind of hope and some kind of help or what to do. And what I've learned is there's very little resources for someone like me still. As much as I've gotten involved and as much as I've tried to talk and raise awareness, there is still a huge stigma about addiction. People are afraid to talk about it, and we who have been through it still don't really have good answers for someone else who is fighting this fight right now. And that's the reason why I will talk anywhere, anytime to anybody and try to come up with a course of action and to just give them some support, someone to talk to, someone that has some sense of what's going on.
It seems to me, Terry, and I think she's really gotten to the heart of the entire discussion that we have to unfortunately call to an end here. But the heart of this whole discussion is prevention and to stop what happened to Dane and what has happened to so many others, 9 people a week. Stop that from happening. And I think the thing that you deal with and that you deal with in prevention, it's the stigma of it.
Yes.
It's people don't understand well enough the nature of addiction. And people have talked here tonight about what it's like. It seems pretty clear to me that that's the biggest thing we have to deal with, the stigma of it. They're just people like you and me, and it can happen to anybody, and it doesn't matter what strata of life, what level of society you're in. It's not people shooting up in alleys.
No. And I think one of the other things that I realize is what you said about why don't they just stop it? Why can't they?
Yeah.
And the people who haven't looked addiction in the eye don't realize that getting them off the drug is the easy part. You can isolate somebody, you can take the drugs away from them, you can put them in rehab, but what goes on in here and the physiology that's changed in their brain, that's what takes so much more time and there's so much more we have to learn. But I'm just grateful for the discussions, I'm grateful for these kinds of opportunities.
Terry, thanks.
Yes.
Thank you.
Thank you.
There are a lot of places that you can find out more about this, but useonlyasdirected.org is the big thing that you should go to as a result of our discussion tonight. There's a lot of stuff. It's a great website. I've looked at it over the last few days. A lot of statistics and a lot of help there, and a lot of preventative measures that you can take. Yeah, did you want to say one quick
I was
thing?
going to say the other issue I would say is that there's not great options for treatment, but there are some options for treatment. And if you call 211 in your county, you will tell you some locations you can go to, private and public. You can get out there, but again, as both Terry and Doug highlighted, it's hard and it's difficult and there aren't great solutions. But prevention is there and it works, treatment is there and it works, and recovery is possible.
And there's hope too.
Yes,
There's
there is
stories of hope. And
Thank you, everybody.
Thank you.
I'd like to thank everybody on the panel, Susanna Burt, Dr. Ray Ward, Dr. Bischoff, Angela Stander. Thanks to Jen and everybody here at 50 West Club and Cafe. Our technical staff is Dave Peterson, Trent Anderson, and Matteo Coletti. This program was produced by Dylan Allred and Corey O'Brien. I'm Bill Allred. Good night.